Okay. And then let me share my screen. Oops. Okay, can you guys see the PowerPoint Ivy Lab 2025?
Yes.
Cool. Thank you. All right. Okay, well, thanks again, everybody, for hopping on. I hope everyone had a lovely holiday. I know it's been a couple months since we've all last checked in, but I'm excited to give everybody updates about what's happened since the holidays, and I'm excited to have Dr. Marcus present her work on the neurofunctional and inflammatory markers among early life stress in a clinical sample of people maintained on buprenorphine for their OUD. But yeah, let's get started. So we had a couple conferences where our lab members attended. We had VASAM and back in November, and here's a few pictures from that. Everyone had wonderful posters to present. And then also at the Immersa conference in November as well. A few pictures from that. And then also in December, we had a few pictures with Dr. Marcus and Dr. Martin together. They both presented work. We also had a new abstract submitted to the College on Problems of Drug Dependence. I think that's in this coming June or July, something like that. And then also one submitted to the American Society of Addiction Medicine conference this year. So that's very exciting. We also had 3 published manuscripts, 2 by Annabeth. Very exciting. I know they took a while. And then we still have a couple in review, but we will be hearing back from them soon about their publication. And then here we have our social media accounts coming up. So this is our Twitter, and if you haven't already, please go ahead and give us a follow so you can stay super up to date. I want to try and move this so you can see the okay, but yeah, at Ivy Lab Social. It's for our Twitter or X. Oops. Okay, I believe this is the next in line, but this is our YouTube channel that I mentioned a bit before. If you need to catch up on some of the previous lab meetings or any other presentations we have posted. And then this is our LinkedIn. And our Instagram. Our Instagram's pretty new, so we don't have that many followers, but we definitely appreciate it if you could help spread the word by giving us a follow and liking some of the posts. And then who is in charge of all the social media? We have a couple lab members, Arjun and Ira. They're both been working wonderfully on keeping up to our social media accounts up to date. As for our current studies that we have going on, we have CBTIO, which is adapting cognitive behavioral therapy for insomnia for people with opioid use disorder. And this is using some data from other projects like SORT and Registry that I'll go into here in a second. But our lead RA on this project is Michelle. And we also have the lab members who are currently working on the project with her. But yeah, projects. Oops, so sorry. But yeah, Project SORT. This project is investigating the relationship between sleep and opioid use disorder recovery. Recruitment is complete, so chart reviews are ongoing, chart abstractions, and we have the lab members currently working on the study with her. And then we have the registry study. This is an ongoing record to track clinical outcomes of pregnant and postpartum patients who seek addiction treatment and recovery with our OB Motivate clinic here at VCU. There are 158 participants enrolled so far, and here are the lab members who are currently working on the project. And another project we have going on right now is called Project Castle, and the lab members on this project are working to develop a computerized intervention that educates pre and medical professionals on substance use disorder stigma. The intervention's been developed already, and I believe if it hasn't been already, the manuscript has been sent off for submission to the IME journal, but I think we're waiting to hear back on that. And then Dr. Marcus is leading the educational studies in the lab. Specifically, the clinical research curriculum study is ongoing, and she has a couple lab members helping her out with that. And then here are a few pending research grants that we have. I believe that's about it. Yeah, and then we have our next lab meeting scheduled for this coming month in February 24 on February 24th at 4:30. I'll send everybody an invite to that once we get into February and this meeting wraps up. But yeah, without further ado, well, if anybody has questions, don't hesitate to reach out to me. And I know a few of you on here are looking to start volunteering with the lab. So if you have any questions about anything, or if you need to follow up with me on anything about getting a meeting with me and Dr. Martin about where we can maybe have you join the lab in some way or form, just reach out to me and we can talk about next steps. But yeah, if anybody doesn't have any questions, then I will hand it over to Dr. Marcus whenever you're ready.
Cool, thanks, Amber. Lots of great updates and exciting stuff happening in the lab. Let me see. I'm getting some weird feedback. My mic.
Uh-oh, I hear you good though.
Okay, it's going away.
Yeah.
Okay,
Okay,
we're
good.
Okay, so hi everybody. If I haven't met you before, I'm Madison Marcus. I'm a postdoc with the Ivy Lab. And just a brief intro about me. So I did my pre-graduate or graduate work within the preclinical substance use disorder field. So I was looking at different behavioral models of substance use disorder and kind of working on in the drug development pipeline from this preclinical perspective. And now for my postdoc, I'm obviously working with the Ivy Lab, doing some clinical research and learning more about that side. So I'm really excited to talk with you all about a project that we actually just submitted the paper for review. So yeah, hopefully we'll hear back about that soon. But yeah, it has a super long title. We're looking at the characterization of neurofunctional and inflammatory markers in the context of early life stress among a clinical sample of people maintained on buprenorphine for opioid use disorder. And I'll break down all those variables. So first, one of the predominant factors that we're interested in with this project is early life stress. And we're interested in early life stress because we know from the general population that early life stress has been shown to influence different neurofunctional endpoints and processes that might be associated with addictive drug-taking behaviors, such as reward processing, cognition, negative emotionality, sleep, things like that. And we also know that early life stress has been associated with this kind of pro-inflammatory state, again, in the general population. So we're looking at not the general population, but specifically our opioid use disorder treatment population. And I think this is really an interesting population to look at because not only do these people have opioid use disorder, and we know that opioid use disorder, people with opioid use disorder oftentimes have experienced a lot of early life stress, but they're also taking buprenorphine, which is a medication for opioid use disorder. And buprenorphine may be exerting some effects on these neurofunctional and inflammatory endpoints that are in opposition to early life stress. So there's been some studies showing that medication for opioid use disorder can reduce this inflammation, this inflammatory state. And also, we know behaviorally that this is an effective medication for opioid use disorder, so it reduces drug-taking behavior. And so we hypothesize that it might be kind of restoring some of these neurofunctional processes that might get disrupted during active drug use. And so this brings me to the aim of this study, where we wanted to determine whether a history of early life stress is associated with a distinct neurofunctional or inflammatory phenotype within our population of individuals maintained on buprenorphine for OUD. And I do just want to mention this is a secondary data analysis from a parent study that some of you guys may have been involved in. Amber recently mentioned it just got published in Drug and Alcohol Disorders. So it was the phase 1 safety study of lemborexant. Thank you to everyone who worked on that study. But I also want to emphasize, even though this is a secondary analysis, all of this data was collected at baseline, so before lemborexant was ever on board. Don't get too hung up on lemborexant. None of these participants had lemborexant. So this was a pretty small preliminary study. We ended up with a total of 21 participants, and I will note that they were mostly male. And some important inclusion and exclusion criteria for this analysis. We had people who have opioid use disorder and are maintained on buprenorphine and are between ages 18 and 65. And then exclusion criteria, we did exclude people who had an uncontrolled serious psychiatric disorder. And our independent variable for the study was early life stress. So we wanted to look at high versus low early life stress. And the way that we operationalized this was based on participant responses to the trauma history questionnaire, or the THQ. So here's a little snippet of what the THQ looks like. It basically asks about a total of 24 different potentially traumatic life experiences that somebody may have had within the realms of crime, general disaster and trauma, and physical and sexual experiences. And so it just asks if the participant has experienced that, and then also approximately what age they were at if they experienced it. And so what we did is we took this participant responses on here and computed a THQ, or early life stress score, from here, where basically we gave participants 1 point for each of the 24 early life stress events that they experienced prior to the age of 18. And so that data distribution is shown here. On the y-axis, we have our THQ score ranging from 0, so they experienced none of those traumatic events, to 24 experiencing all of those traumatic events. And you can see we have a pretty good distribution of scores. What we ended up doing to make this into 2 different groups is we took people who scored below or average and below average on those scores and classified them as low early life stress group, and the people who scored higher as the high early life stress group. And this let us have 2 groups of about equal sizes so that we could compare. Sorry, I keep moving you guys around so I can see the whole slide. Okay, so then we have our dependent variables. So one of the dependent variables we're interested in is inflammation. So we're looking at peripheral levels of different inflammatory markers. We had a total of 10 different cytokines that we looked at, in addition to CRP, LBP, and MCP1, and we assessed those via just blood draw from our participants. And then we also looked at performance across 6 different neurofunctional domains. Those domains were reward, cognition, negative emotionality, interoception, metacognition, and sleep. And because you guys are an expert audience and may be familiar with some of these assessments, I just wanted to show this chart showing the different neurofunctional domains here and the associated measures that we used to assess these different neurofunctional domains. So next I'll get into results, but I did want to pause here and just see if anyone has any clarifying questions about the methods or anything that I can clear up. And feel free to shout it out.
Madison. Hey,
Yes.
sorry, I was late coming on the computer. Hi, everyone. Thanks for coming. Um, I thought maybe just clarifying where these patients came from might give some clinical context too, who were in the trial.
Sure. So yeah, these were patients who came, like I said, from the lumberexant trial. So is that what you're asking? So these are patients who had insomnia, but we're not really looking at that. And oh, they're patients from the VCU Motivate clinic.
Yeah, most of them came from Motivator, a different like outpatient clinic. So then they were stabilized on their Suboxone, rather than patients who are maybe like starting and not really stable on their buprenorphine. But these were patients that were pretty stable on their buprenorphine.
Yes.
Good job.
Okay. Cool. We'll go into results. So first I want to show some of the demographics associated that we had, demographic results that we had. So in just to familiarize you guys with how I'll show these results. So in the two columns, we have our participants who were in the low early life stress group and then the high early life stress group, and then the p-value comparison between the two early life stress groups. And then here we have a range of different demographic and clinical variables that we looked at. So looking at this first row, we can see, I kind of showed you a preview before, but the people in the low early life stress group had experienced about 3 traumatic events prior to the age of 18. And people in the high early life stress group experienced about 9 traumatic events prior to the age of 18. And then as we kind of look down this row here, importantly, we're seeing that our ELS groups did not differ with respect to age, sex, buprenorphine dose or duration, BMI, tobacco smoking status, substance use disorder, or psychiatric comorbidity. And so that's all important, good background information to have as we go forward and look at our main dependent variables. So here's another big complicated chart organized in the same way, but basically here in bold, we have all the 6 different neurofunctional domains that we looked at, and then the scores and subscores on all of those different assessments. And I can really quickly summarize this by telling you that there were no neurofunctional differences between the early life stress groups across any of the 6 domains that we looked at. So this may be due to a small sample size, or not using the right instruments, or just a lack of a difference in the population. Some kind of more exciting results happened when we looked at these inflammatory endpoints. So on the y-axis here, we have our estimated concentration of all of our different cytokines that we looked at, spread here across the x-axis. And then we have our high and low early life stress groups indicated by the 2 different symbols. And so what I want to highlight here is that for the pro-inflammatory cytokine IFN gamma and IL-6, this was actually higher in the high early life stress groups compared to the low early life stress group. And then if we look at what's typically considered a more anti-inflammatory cytokine IL-13, we see that this trend is flipped. So it's higher in the low early life stress group than the high early life stress group. So this is pretty cool that even with this small sample size, we're seeing a hint of a difference here. I mentioned we also looked at CRP, MCP1, and LBP. I'll show you the results here, but there were no significant differences in any of those endpoints between the ELS groups. So I think what's really cool about this study, like I just said, is that even though we have this really small sample size, we're able to pick up on these hints of a difference between ELS groups and these inflammatory markers. And I think this is also really cool when you consider that the people in this study are were about 40-ish years old, and we're separating them into groups based on things that happened to them prior to the age of 18. And also, these are patients who are stable on their buprenorphine treatment. And so these are biological changes that are persisting for a very long amount of time, and despite, going under treatment for opioid use disorder. Obviously, this is a very preliminary study. So there are tons of future directions that we can look at. One thing that we would love to look at is sex differences. So there's some literature to suggest that differences in or the pro-inflammatory state is more distinct in females compared to males associated with early life stress. So I think that would be a really interesting comparison to look at with a larger sample size. Also, we operationalize early life stress based on the number of traumatic events that somebody experienced. This is certainly not the only way, and probably not even the best way to operationalize early life stress. So another way that we could do this is by looking at the effects of different types of early life stress. So there's some literature looking at abuse versus neglect having different effects, or like physical versus emotional abuse, and seeing how that pans out. And then, of course, our end goal with all of this is to help improve treatment outcomes. And so what we're missing from this study is looking at any kind of indicator of treatment outcomes. And so I think it would be interesting to see if people with these different inflammatory or neurocognitive profiles show differences in things like recovery capital or time on buprenorphine. And like all of these different treatment outcomes that we really care about in clinic. So yeah, eventually the goal of this work is to aid in tailoring some buprenorphine-based OUD treatment regimens to individuals' biopsychosocial needs. But that is, further down the pipeline. So I'll end there with some references. Want to acknowledge all the different co-authors who helped work on this paper, all the people who were collected the parent study data, and then our lab funding for this project. So yeah, I'll go right there and open it up for questions.
Great job, Madison. Thank you so much. It's always good. It's always exciting to be able to to see signals of things, even when we're kind of close, before we move farther down the pipeline. So I'll open it up for questions that anyone has, or any other inquiries.
Oh, can everybody hear me? Hi,
Yes.
my name's Leah. I am a MD PhD student and going to be rotating in the lab this summer. I just wanted to say that I found the findings very interesting because I used to work in Dr. Nora Volkal's neuroimaging lab at NIH, where we looked at a lot of like functional connectivity changes in people in recovery for opioid use. And it's very interesting how you found like this biological factor, and also we're looking at these biological factors and seeing some significant results. So I'm curious how these factors would like have an interplay and like those variables relating. It's just a comment. It's really interesting though.
Yeah, thank you. Yeah, and yeah, Dr. Volkal's work is super cool. So it's awesome that you're able to work on those projects. Really great.
I'll just make a comment. I've on like what Leah just said. I've seen other work kind of learning more in this space as Madison and I've been kind of delving into this recently, in that from a neuroimaging standpoint, that in other mental health conditions like depression, et cetera, that there are correlates that they've found with by these kind of same variables with early life trauma, stress, et cetera, and these inflammatory markers and how they correlate with changes in established neuroimaging findings and other mental health conditions, but that hasn't been extended yet into substance use disorders, and how kind of all the things interplay. but I wouldn't be surprised if if it's going to be an extension into this area. Um, and some of that's been done in a preliminary way. What's interesting from what we focus on, because in the Ivy lab, we focus a lot on people who are already in treatment and established in treatment, whereas a lot of these types of translational studies are typically done for people who maybe have a substance use disorder and are not yet in recovery and not in treatment or starting treatment initially, et cetera. So it kind of just behooves us that, these people like on a clinical, you would say, oh, this patient's stable, and like they would just be really simple, right? We're like, oh, they're just stable clinically, but then we still have a 60% dropout rate in treatment. And so finding these correlations now, even in this quote stable clinical population, I think just shows that all of this great work that's being done in the pre-treatment space, we need to continue to work even after people get into treatment to make sure that they continue to do well. Anyone else have any questions?
Hi, y'all. I'm Rohan. I'm a first year, and this is my first time attending this lab, and also seeing this is really cool. My previous research in undergrad was actually on sort of some of these inflammatory markers and their impacts on reaction to diseases. And so we looked like for mine, I saw the connection here. If you go back to the slide previous to this, I thought it was really interesting that there was a specific increase in IL-6 levels in patients. And I wanted and I'll tell a little bit about why I found this interesting. Then I want to ask my question because IL-6, of course, like is as a cytokine, is associated actually. My research was on COVID-19 and inflammatory cytokines and how the levels of inflammatory cytokines pre-COVID-19 actually predicted rates of long COVID and serious COVID complications. One of the markers that I remember I looked at was IL-6, and one of the potential pathophys was because of the downregulation of T cells, the increased neutrophils, and the decreased sort of viral response. Like acute phase, like the increased acute phase response led to a worse acute phase response to the virus. So I wanted to get your take on if you know what why would these specific cytokines be increased in these patients with these early life experiences?
Yeah, that's a great question. And you, working in kind of that immune space, probably know a little bit, uh, have a little bit more expertise in that than I do. But what I can tell you is that from like looking at these different cytokines, so IL-6, like you mentioned, is one of these like really classic cytokines that people find lots of results on. There's a big literature on it. And so we were really excited also when we saw that we saw a difference in IL-6, and that this is also really consistent with what we see in the general population of people with early life stress showing increases in IL-6. But I do think that, and this is super preliminary. So some of these differences that we're seeing or not seeing, I don't want to read too much into that. But I do think that it is interesting that we're seeing, differences in IL-6, but we're not seeing differences in some of these other more stable inflammatory markers like CRP, that also the literature says in the general population, we see an increase in people with early life stress. So as far as, why we're seeing an increase in some of these select cytokine measures, I'm not sure. I'm not sure if that's, I guess I'm chalking it up to small sample size. But yeah, I think it's great. And I know like IL-6 and TNF alpha often are like kind of cycled together. So why are we seeing changes in one but not the other? Yeah, I think these are all great questions to explore further down. I don't know if that answers your question, but that's that's my take on it.
I feel like my question might have been, it's a very tough thing and kind of probably a field of research currently, but you really enlightened me on this. Thank you.
Yeah, and then with LBP, we were interested in like gut inflammation. We have someone in our research group who's really interested in that, so that's why we looked at LBP. Um, but yeah, no differences there. Yeah.
Anyone else have any questions or comments?
I'm just wondering if anyone in your group is doing any microbiome work. And because that's so tied to inflammation. Or is it something you want to do in the future?
Yeah, so I'm not doing that, but there are people in this group who kind of created this project who are doing that, specifically with like gut microbiome and early life stress. So yeah, stay tuned, I guess.
Yeah, I can speak. There is someone else on the breakthrough group, the kind of the internal grant that funded this study, um, who's focused on the microbiome, but those analyses haven't been done yet. Those samples, we had these samples already available, so they were much easier to acquire. We just had to pay for the analyses to get done, so that was good. But what this work is doing now is kind of cool in that Gretchen Nye's lab is not necessarily working from these findings. They're kind of happening in parallel, but they're kind of, quote, backtracking back into the animal space. And so looking at a more controlled experiments, looking at stress, et cetera, over time and opioid and also with opioid exposure and being able to look at, the T regs and such that someone else already mentioned. So it's really interesting to be able to see these findings in the clinical population and then use that to inform how to questions that you can more easily, more manipulate more rigorously in animal studies. So stay tuned. That stuff is still, those findings are still in the queue right now.
Yeah, it's exciting.
Mm-hmm. Amber, did you have a question?
I was just gonna ask Madison if, like, what's the next steps with you on the project? I know there's a bunch of, you guys talked about just future work. Are you gonna play a hand in that future work, or, because you mentioned it was a group effort, so.
Yeah, I would love to. I think kind of what we're doing as the Ivy Lab and kind of moving this work forward, and what I've also been doing personally is in all the new research studies that we have coming up, writing into the protocol that we're going to take these different measures of early life stress. So whether that's the trauma history questionnaire, we're also expanding that to some other measures of early life stress, like the childhood trauma questionnaire and the ACEs. So incorporating those measures and baseline so that if we want to do additional studies, we can. And then likewise, also incorporating some blood sampling into our like pre and post time points for those studies so that we can look at these inflammatory endpoints or other endpoints that we might be interested in as this work kind of progresses and increase our sample size.
That's cool. It's really interesting. Is that just going to be for Limbrexant, or are we doing that for Suvorexant as well? Or I can't imagine
Yeah,
that we would do it for CBTIO, but
yeah, definitely for lumberexant, we're building all of that in. Suvorexant have less control over what's
yeah.
happening there. Yeah, who knows? Would be great.
So cool though. Okay, cool.
What other questions or comments do people have? Well, I'll just say that with what you were just explaining, Madison, that's exciting is that with the upcoming studies, when we actually plan this ahead of time, rather than this was a secondary analysis, we'll be able to look at these things pre-post also when people are actually getting treatment and we're following their treatment outcomes, which we didn't have with this analysis. So that's going to be interesting to be able to look at that data later on in a prospective manner. So it's been really exciting to be able to use this, which came out just in time for us to write those protocols to include it later on. Well, great. Well, Madison, that was wonderful. Thank you so much for sharing that wonderful work and great job.
Yeah, absolutely.
Yeah. This paper is in review right now, so we're just waiting on hearing about its publication going forward. So,
Yay.
yay. Well, thank you everyone for coming to our January lab meeting. We look forward to seeing everyone at future lab meetings as we get things up and going for the new year. Amber, do you have anything else for people before we hop off?
No, it is a little bit early, so I guess if anybody has general questions about next steps moving forward, feel free to speak up now, or you can just email me, and then I'd be happy to connect you with what to do next. But if that's it, then I guess we'll just wrap up a little early tonight.
Sounds good.
Alrighty.
Well, thank you everyone for coming.
Yeah, just keep
Okay.
an eye out for the February meeting. I'll send that out in the next week or so.
Yeah.
But thanks again, everyone.